Thank you. I am Sang-Min Park from Seoul National University Bundang Hospital. I am orthopedic spine surgeon and specialize lumbar minimal invasive surgery.
Over the past decade, the number of publications on biportal endoscopy has grown explosively. In 2025 alone, an astounding 241 papers have been published in the literature, reflecting the growing interest and adoption of this minimally invasive surgical technique worldwide.
However, high-quality evidence remains limited. Although there are a total of 12 randomized controlled trials, only 7 of these are head-to-head comparison studies analyzing surgical techniques. Among these 7 studies, I have authored 4 papers. One was authored by Professor Park Si-young, and 2 studies have come from China. This demonstrates the significant contributions from our institution to the evidence base for biportal endoscopy.
Let me present one of my published studies. This is a laminectomy comparison study published in the Spine Journal in 2020, which has been cited 200 times. It was a non-inferiority trial comparing biportal endoscopy with microscopic surgery. The clinical outcomes were similar between the two approaches. However, biportal endoscopy showed advantages in reducing postoperative pain and fentanyl usage. Nevertheless, there were no significant differences in other measured parameters between the two techniques.
In the early postoperative period, pain in the biportal endoscopy group was somewhat lower compared to the microscopic group. However, the difference in visual analog scale scores was less than 1 point, which has no clinical significance. This finding suggests that while biportal endoscopy may have a slight advantage in early pain management, the actual clinical benefit is minimal.
This is another paper we recently published in Clinical Orthopaedics and Related Research. This was an equivalence trial, and it showed somewhat different results compared to our previous study. While clinical outcomes showed no difference between approaches, the postoperative pain and muscle damage results were different from our earlier findings. This suggests that the reduced low back pain and muscle damage observed in biportal endoscopy may potentially be random effects rather than consistent advantages of the technique.
Next, I will discuss a non-inferiority trial on discectomy published in 2023. In this study, we reported that biportal endoscopic discectomy resulted in slightly less postoperative low back pain and less muscle damage compared to microscopic discectomy. However, in other measured outcomes, there were no significant differences between the two approaches.
Similarly, we conducted an equivalence trial for discectomy and found comparable clinical outcomes between the two techniques. In this study, both short-term visual analog scale improvement and muscle damage results were favorable in the biportal group, and we reported fewer wound complications. Overall, discectomy results demonstrated comparatively better outcomes with biportal endoscopy compared to microscopic approaches.
When we combined the data from these two equivalence trials to analyze safety outcomes, we found similar complication rates between biportal endoscopic and microscopic techniques. However, regarding wound dehiscence, biportal endoscopic demonstrated a significant advantage, with substantially fewer wound complications compared to the microscopic approach. Biportal endoscopic spine surgery has demonstrated significant improvements in both pain and function across multiple studies. Patients consistently report high satisfaction rates with this surgical technique. The overall complication rate is 7.79%. Common complications include hematoma at 3.79%, dural tear at 2.23%, and incomplete decompression at 1.29%. Overall, biportal endoscopy has proven to be a safe and effective surgical technique.
In our analysis of surgical site infection risk in biportal endoscopy patients, we found only 3 cases of infection out of 436 patients, representing a very low infection rate of 0.7%. Among these cases, there was 1 superficial infection and 2 deep infections. Diabetes mellitus was found to be a significant risk factor for infection. However, other common risk factors such as age, sex, smoking status, and body mass index were not found to be statistically significant risk factors for infection.
When comparing biportal endoscopy with uniportal endoscopy in terms of quality-adjusted life years, we found similar clinical outcomes between the two approaches. Biportal endoscopy demonstrated slightly higher costs and quality-adjusted life years gained at 0.46 versus 0.36 in the uniportal group, but this difference was not statistically significant. The longer operative time and greater estimated blood loss resulted in higher nursing costs. Despite these considerations, the incremental cost-effectiveness ratio was only $354.5 adjusted life year gained, demonstrating good value.
Our MRI analysis comparing tubular versus bilateral biportal endoscopy revealed similar clinical outcomes between the two techniques. However, biportal endoscopy provided superior decompression with greater increases in both anteroposterior diameter and dural sac surface area. The biportal approach did require longer operative time and was associated with higher rates of symptomatic hematoma, which are important considerations when selecting the surgical approach.
Regarding postoperative epidural hematoma formation, we conducted a randomized controlled trial comparing biportal endoscopic spine surgery with conventional microscopic surgery. Our analysis showed that both the dural sac measurements prior to surgery and postoperative changes were comparable between groups. However, there was a statistically significant difference in hematoma formation rates, with conventional microscopic surgery showing higher rates of symptomatic hematoma formation compared to biportal endoscopy.
We also studied biportal endoscopic decompression in patients with degenerative lumbar spondylolisthesis with stenosis. The results showed improvement in visual analog pain scores for both back pain and leg pain from preoperative baseline through final follow-up. The Oswestry Disability Index also improved significantly from baseline. Importantly, patients treated with the biportal endoscopic approach demonstrated comparable or superior outcomes compared to conventional approaches.
In our study of biportal endoscopic discectomy versus microscopic discectomy for treating herniated disc in obese patients, we found similar clinical results between the two techniques. However, the biportal endoscopic approach demonstrated significant advantages in reducing wound dehiscence and recurrent disc herniation compared to the microscopic approach, which are particularly beneficial considerations for the obese patient population.
We evaluated biportal endoscopic lumbar discectomy in patients with cauda equina syndrome caused by herniated disc. Our recovery data showed excellent functional restoration, with bladder recovery achieved in 86.7% of patients and bowel recovery in 85%. Lower extremity function recovered completely in 50% of patients and partially in 21.9%. For cases presenting more than 48 hours after symptom onset, we achieved complete recovery in 9 patients and partial recovery in 3 patients, demonstrating the effectiveness of urgent surgical intervention.
When we compared biportal endoscopic revision discectomy with open discectomy for recurrent disc herniation, the biportal endoscopic approach demonstrated faster early recovery with lower visual analog pain scores at both 2 days and 2 weeks postoperatively. Additionally, the endoscopic technique resulted in shorter operative time and shorter hospital stay. Importantly, 1-year clinical outcomes were similar between the two approaches, suggesting that the biportal endoscopic technique offers advantages during the early recovery period. As we look toward the future of biportal endoscopic spine surgery, several emerging technologies show great promise. Navigation systems will improve surgical precision and safety. Augmented reality technology will provide enhanced visualization of surgical anatomy and critical structures. Additionally, artificial intelligence-based segmentation will assist in intraoperative decision-making, further improving the safety and effectiveness of minimally invasive spine procedures.
When working on the inner cortex, we can use the probe to verify our progress. On the navigation monitor, you can see that the probe tip directly contacts the inner cortex. This real-time confirmation allows us to safely continue the decompression with unnecessary removal of bone.
Here you can see the laminectomy from another angle. Sometimes during surgery, it can be confusing to identify the exact part of the lamina being removed. With the navigation system, we can continuously confirm the precise location, which greatly improves both accuracy and confidence during the procedure.
AR technology that overlays surgical plans, dangerous structures such as neural or vascular tissue, and surgical tools on the surgical field is also being developed.
This is a robot from China, Tanavi. This is also not specifically designed for endoscopy, but for screw positioning. They use the robot to position and stabilize the endoscope for PELD procedures. Compared to conventional PELD, they reported better results in puncture time, fluoroscopy time, and operative time, with C-arm-based robots showing the least fluoroscopy time.
These robotic systems can be applied from planning to completion of surgery. Advances in technology can be applied to each stage of the surgery, helping to make it accurate, safe, and convenient.
Let me show you the robot-assisted biportal endoscopic surgery that we're researching. It's a robotic device consisting of an endoscope arm and working arm. It's a master-slave type that can be controlled remotely. The left hand controls the endoscope arm, and the right hand controls instruments like burrs. In the video, the right hand is controlling the endoscope burr. The actual burr movement is designed to be smaller than the right hand movement.
Next is the punch video. We implemented the punch, but it was quite difficult. We configured the robot arm with 6 axes, but since actual punches don't move in 6 axes, it was very challenging. For one portal endoscopy, it might be sufficient, but for biportal endoscopy, 6 axes is quite difficult.
We are currently developing real-time segmentation technology for biportal endoscopic images. This artificial intelligence-based system automatically identifies and highlights important anatomical structures in the surgical field. Our research demonstrates impressive accuracy of over 94% in real-time bone and tissue segmentation. This technology has the potential to significantly enhance surgical visualization and safety by helping surgeons identify critical structures automatically, reducing the risk of inadvertent injury to vital tissues during minimally invasive procedures. In summary, biportal endoscopic decompression and discectomy represent a safe and effective alternative to conventional microscopic approaches. We have demonstrated comparable clinical outcomes with advantages in early postoperative pain management and faster recovery. The technique shows particular benefits in complex cases, including revision surgery, obesity, advanced age, and Caudy-Aquina syndromes. As we continue to integrate emerging technologies such as navigation systems, augmented reality, and artificial intelligence segmentation, the future of minimally invasive spine surgery is very promising. Thank you for your attention.
Thank you very much for your attention. I appreciate the opportunity to share our research and clinical experience in biportal endoscopic spine surgery. We welcome your questions and look forward to collaborating with colleagues to advance the field of minimally invasive spine surgery. Thank you.